want to talk a little bit about how we can operationalize survivorship care, why that's important, and I know that's a pretty innate question for you guys, and then what we're trying to do locally about that in the future, and this is alluded to by Dr. Nyaming. So why is the patient perspective important? Well, in short, because the physician perspective is wrong. So all too often, historically in prostate cancer, we relied on the physician simply asking men, how are you doing? And when we asked physicians to report how they were doing and tell us how their patients were doing, you can see that in the blue bar, they dramatically underreported the burden of symptoms that their patients were experiencing. And when you looked at what patients were self-reporting, they were reporting high rates of urinary problems, high rates of sexual dysfunction, things that the physician wasn't capturing because they weren't asking the patient directly, or they weren't asking the patient to complete what we call patient-reported outcomes. What happens with time that is relevant to the context of a prostate cancer diagnosis? Well, prostate cancer occurs in a majority older patient population. So most men with prostate cancer are at least 50 years of age. That's not universal. And as we get older, there are some things that naturally happen. We have an increasing burden of urinary symptoms. We have an increasing burden of sexual dysfunction. But you can see in the circles at the top that these side effects, and with respect to this graph, we're looking specifically at erectile dysfunction, are much more pronounced in prostate cancer patients. And if we're not assessing those and acting on those, we're doing a disservice to our patient population. Traditionally, our understanding of patient perspectives of survivorship care looks like this. So these were some curves that I created when I was a fellow, which when I first started giving a talk at this seminar, there was some recency to that. Now that was a long, long time ago. But the idea of these curves was, what is your probability of returning to your baseline self? This is answering a very patient-centered question of, what is the likelihood that I can be like I was before? And you can see with respect to urinary control, there is a dramatic drop-off in urinary control in the green bar right after someone has surgery to remove their prostate. But over time, their recovery gets better and better and better. And the idea behind curves like this would be that someone would take these curves, a doctor in their office, a patient at home, and try to understand sort of their symptom trajectory and whether the symptoms that they were experiencing are normal, are abnormal, are they doing better than they would expect, are they doing worse than they would expect, and that would activate them to do something about their symptom burden. You can see similar curves for sexual function. So this is the idea that you would return to your baseline. This is not saying that you would not be a functional sexual being. This is just saying that the likelihood of you returning to your sexual function that you had before your prostate cancer treatment is very low. And then when you look at bowel function, all the treatments that we deliver for prostate cancer affect in some way bowel function, but the magnitude of that impact is a lot less. So these are some updated curves from a massive nationally representative registry, and what you see are some similar drop-offs. So with respect to urinary function, all of the treatments that we deliver for prostate cancer have some impact on urinary function and urinary control. And you can see that over time, there is an effect that might be pursuant to the fact that we're all getting a little bit older over time, and might be pursuant to the fact that some of the therapies, like radiation-based therapies, can have some chronicity of effect and some long-term health effects. So these are the curves that we have generated for the purpose of research, for the purpose of characterizing patient symptom trajectory, but there are huge gaps in taking that data and actually using it for your clinical care. And part of it is, if we want to create something that allows you to better understand your symptom burden, one of the key questions you may have is, well, how am I doing compared to men like me? So accessing comparative data is a big gap in how we can operationalize this data. Most of the data that I've showed you is for men with localized prostate cancer. There haven't been large registries for men with recurrent or advanced prostate cancer. So being able to compare men in those challenging decision-making arenas is hard when we don't have comparative data. And then an all too under-considered patient population, the caregiver. So it's important to recognize that prostate cancer doesn't just impact the patient, it also impacts their caregivers, which predominantly are spouses. So what we have created in partnership with Movember is a tool that operationalizes patient-reported outcome data for survivorship care. And it has three important phases. It has user data entry, where you can enter clinical information about yourself, and that allows us to match the severity of your cancer with the severity of cancer within our system. And it allows us to collect your patient-reported outcomes. And then we create what we call a dashboard, which shows you your symptom trajectory with a bar of symptoms that is sort of a range of symptoms for men like you. And that allows you to answer that patient-centered question of how am I doing compared to men like me, but it also allows you to generate expectations. You know, what can I expect in the future? And then there's output based on your responses that includes self-management content. So if you had surgery and you're reporting bothersome urinary incontinence, it outputs content on how to manage post-prostatectomy incontinence. This is what it looks like. This is our future state. So the future state would be that this is actually embedded within our Epic electronic health record. We're not quite there yet, unfortunately. And why is this important? Well, this is important because understanding symptom trajectories in this clinical space is not just to characterize and inform, but it's also to act. So what is unique about the symptom side effects that are related to prostate cancer treatment is we have management options for those. So for patients with urinary incontinence, you know, this is just showing two surgical options, but we have physical therapy. We have home-based behavioral therapies. And for more extreme cases, we have male urethral slings and artificial urethral sphincters. And the idea between those two surgeries is to in some way increase the support on the urethra or actually mechanically allow for coaptation closure of the urethra using a mechanical sphincter device. For erectile dysfunction, you know, the experts in our Men's Health Center will say fairly boldly, all erectile dysfunction can be cured. It just depends on what lengths you want to go to cure it. And so we have things like pills. There are suppositories you can insert into the urethra. There are injections that you can deliver directly, medications, into the erection tubes of the penis. And then there are more extreme interventions that are clearly invasive, but also incredibly effective, like an inflatable penile prosthesis. So understanding those symptom deficits is really important because we actually have available management strategies to address those symptom side effects. Well, how can we do a better job in the future? So the joke I always make is, you know, they have this statistic that physicians, mathematicians, they all do their best work in their late 20s and early 30s. So I am past my creative prime. So I can't think of good research questions anymore. So how can I harness the patient experience to better understand what is important to you so that I can ask better research questions that address issues that create more generalizable research products? So how can we do a better job of making prostate cancer care better by actually doing the research that's important to you? So there are some people in this room that had a huge hand in us being able to do this. We've been working via the SPORE and in partnership with us2 for several years to try to create what's called a patient survey network. And the idea of this patient survey network is that we can, the key did not show up on this, but the key to this patient survey network is trying to understand what research questions are important to patients. We've done something similar in bladder cancer, and it's allowed us to initiate what we call translational health services research. So because we are a huge institution with a tremendous research infrastructure, we can take these research questions and we can actually answer them. And so what this is supposed to be is this is supposed to be the demographics of our patient survey network. And unfortunately, the blue bar is white respondents. And so one of the things that we're very excited about is this partnership with FEN that Dr. Nyame discussed, which would allow us to increase the diversity of our patient survey network. And that's critical because if the patient survey network is not generalizable, then the research questions we get back from it won't represent the voice of all men with prostate cancer. But you can see in a week and a half, we've gotten almost 600 responses, which is very exciting. We have patients in the system, but we also have caregivers. As you would expect, most of the caregivers are spouses. And what we've been able to glean from this first round of the patient survey network are some pretty impressively prioritized research questions that we can then take and figure out how to answer. So some of the prioritized research questions that appear to be top priorities for patients for localized prostate cancer include, well, gosh, there are a number of decision support tools available for localized prostate cancer. How do you know what to use? How do you know which one works best? Which one best represents the preferences that you have for your prostate cancer side effects? How can we as doctors do a better job? So, you have this small black box of time in that doctor's office to understand how to make a treatment decision. That is incredibly difficult. How can we improve the counseling ability of doctors regarding the side effects of prostate cancer treatment? And then some aftercare issues. How do we do a better job after prostate cancer treatment, understanding factors related to your prostate cancer trajectory that can impact survival and quality of life? Recurrent prostate cancer. So these are patients for whom after radiation, after surgery, their PSA has climbed again. How can you make decisions in that space? So it's very important to remember that when we talk about over-treatment or over-diagnosis of localized prostate cancer, so this idea that some prostate cancers don't necessarily have to be treated primarily, well, maybe some recurrent prostate cancers don't need to be treated primarily or don't need to immediately receive hormone therapy or other interventions. So are there even available decision-making tools for that complex clinical space? How useful is addressing a recurrence early with androgen deprivation therapy? And some of these new imaging techniques that Dr. Yu is going to talk about, well, how do they compare in terms of their usefulness in detecting recurrent prostate cancer? And then lastly, advanced prostate cancer. It used to be that we had one or two treatments available, and now we have this panoply of treatments available for metastatic prostate cancer. How do you make decisions about what comes first or what comes second? Or even in the context of the available therapies today, what comes fourth? What about how these therapies differ with respect to important patient-centered outcomes like quality of life, caregiver burden, financial toxicity? When we look at the clinical trials for these therapies, they look at hard endpoints like disease-specific survival and overall survival, but all too often they omit some of these important patient-centered outcomes. And what is the best time to add chemotherapy or immunotherapy in the context of advanced prostate cancer? So I think we would all agree that a lot of these questions are really important to us as clinicians, but this allows us to assign some priority for how we address some of these questions because they're clearly important to patients as well. One of the things I want to mention is that this is only the first round of this, and one thing that we include in this patient survey network is an open text box for patients to submit their own questions. And that's really critical because the key to this patient survey network is what are the questions that we are not asking because we don't share this journey necessarily. That because we aren't experiencing the life of a prostate cancer patient, there are questions that we just can't ask. And so of those 600 responses, we've gotten over 300 open text responses. And so I'm very excited to wade through those to try to understand what are the questions that haven't yet been asked. So thank you very much.
Wonderful. So I'd like to invite all four speakers to come up to the front. If you have questions, please write them down on the card and send them to the end of the row, and I'll collate them and ask them.